Hello and welcome to today's episode of BioTherapy Live. Today's guest is Dr. Tippett. I'll tell you a little bit about Dr. Tippett and then hand the controls over to her. Dr. Tippett has been a longtime member of the Baer Foundation and a supporter and practitioner of biotherapy. She achieved her bachelor's degree in chemical engineering from the University of Missouri, and then her medical degree from the University of Cincinnati. She is board certified in family medicine and pain management and palliative care and wound care. She is a practicing solo family physician in Ohio with primary focus in wound care using a bioengineering approach. She spends a significant amount of time consulting for nursing homes, hospitals, clinic practice, and a real focus on wound care, having treated over 15,000 wounds to date. Her main interests in wound care are limb salvage and pressure ulcer prevention and treatment. She is the founder and president of the Hope of Healing Foundation, dedicated to limb salvage and innovative wound treatments, and has been honored by numerous awards, including one from the Baer Foundation, if I'm not mistaken. And has also published a book called Hear Our Cry, which is a 20-year history of wound care and amputation. She is very well qualified to share her experiences today in leech therapy and maggot therapy, and that's exactly what she's going to do. So welcome, Dr. Tippett. The audience, the computer, they're yours.
Thank you, Ron. It was a very nice introduction. I have to say, I'm not what you described. I did for 20 years. I don't do that anymore. I'm retired from some of that. I do hospice work still. I'm a hospice medical director, and I'm a civil surgeon. I do immigration physicals every week. And I do consulting work, like I just talked about, getting maggots for the man in Indiana. So I stay quite busy, even though I don't have an office anymore, a practice in my office anymore. But today I want to talk about my favorite maggot and leech stories. I've done 20 years of maggot and leech therapy, and I have a lot of stories, but there's a few that are my favorite. So, Albert, you got my slide up? Okay, and we're going to start with maggot therapy because that's the bigger part. I've done 15 years of maggots, well, 20 years of maggots, and I only have about 5 years of leech treatments. Next slide. So, no, go back one. This comes from a talk that Ron and I did at SAWC a few years back. And Ron titled it Maggot Therapy, Back to the Future of Wound Care, which I thought was very clever. But next slide, we're going to talk about maggots a little bit. And, you know, you may already know all this, but we're going to talk about debridement therapy. And our objectives are, you should know 4 indications and 3 warnings or relative contraindications for maggot therapy. Describe 3 ways that we control therapeutic myiasis, maggot therapy, to ensure safety and efficacy. Describe 3 mechanisms of action, and be able to apply maggot dressings with confidence. Next slide. It all started with Dr. Baer, William Baer. In World War I, he treated soldiers with maggots, and he said if you debride with maggots, the wounds heal normally. And if you continue applying maggots after the wound has been debrided, the wounds heal even faster than normal. He published his results, and maggots were just the way to go. Everyone wanted maggots. You could buy them from literally a lot of different supply houses sold maggots. You could get maggots anywhere. So it was really the thing to do. Right, next slide. It became the thing to do until the 40s. And the popularity decreased because maybe improved surgical techniques during World War II. I don't know if that's true. Big thing was newly available antibiotics. Antibiotics really put the kibosh down on use of maggots, and maybe reduced incidence of wounds. Again, I doubt that, but maybe it was. Next slide, please. And then current status in 2003, FDA began regulating medicinal maggots. In 2004, they permitted marketing of medical maggots for debriding non-healing necrotic skin and soft tissue wounds, including pressure ulcers, venous stasis ulcers, neuropathic foot ulcers, non-healing traumatic or post-surgical wounds. So that's quite a big range of wounds that maggots are approved for. Next slide. And by 2013, there were 25 laboratories worldwide that were selling maggots, and patients were treated in over 30 countries with over 50,000 maggot treatments being done. So maggots came back into the main line again, even though, as Diana said, you wouldn't believe that because some of these doctors and hospitals and hospices are still, they're back pre-World War II, pre-World War I, saying we don't use maggots. Next slide. So what would be the motivation to readopt maggot therapy? One, chronic wounds are still a problem. And now you have antimicrobial resistance, which is a big problem. And now, of course, there's clinical studies that are available that show how good the maggots are. And you have personal successes. More and more people are using them and sharing their success. So that all helps motivate readoption of maggot therapy. Next slide. When you look at maggot therapy, there's 3 mechanisms of action. Number 1 is debridement, which is enzymatic and mechanical. Number 2 is disinfection. Maggots kill bacteria and they dissolve and inhibit biofilm, which more and more, when you go to any wound conferences, you hear all about biofilm. Maggots dissolve and inhibit biofilm, and they promote wound healing. There's granulation tissue growth, there's epithelial proliferation and migration, and there's tissue oxygenation. So the mechanism of action are very important. Next slide, please. Here's a picture of our maggot. This is Venetia sericata, or Lucilia sericata, some say. Anyway, you can see how the maggot wiggles around and has rough band and their little teeth, and they can mechanically debride as well as enzymatically debride. Next slide. Here is a graph of maggot therapy versus conservative debridement for the treatment of pressure ulcers. This is time in weeks, and here you see conservative treatment. Next slide, please. And now that line shows the maggots. So you can see that you had a really higher growth of percent of granulation tissue for the pressure ulcers. Okay, then our next slide shows diabetic foot ulcers. Same thing, you have the lower line is the conventional treatment and the upper line is with maggot therapy. So you have graphs showing how successful maggot therapy is in both diabetic foot ulcers and pressure ulcers. Next slide. Here's the life cycle of the blowfly. You have your adult. The blowfly is actually, I think, an attractive fly, really. It's not like a pesky little black fly. It's a very more slow-moving, graceful, green-colored fly. Anyway, you appreciate them after you've done maggot therapy enough that you see how good they are. And they lay eggs within 12 to 24 hours, and the eggs then become the larva, which is what we're using for maggot therapy. And then these pupate 10 to 20 days and then turn back into an adult. So if you're doing maggot therapy, you only have the larva. You don't have adult flies. You don't open up after you're done treating and have flies come out. You just have fat larvae. Okay, next slide, please. That was a question my patient asked me. She said, will flies come out? I said, no, just fat larvae. So maggot therapy is a controlled therapeutic myiasis, maggot infestation. And the methods of treatment and potential complications are predicted by studying the natural history of myiasis. So if you know what to expect, you know what to do. Not all species are therapeutic or safe. Not all strains of the same species are equal. Most successful therapists understand the biology and the natural progress. Next slide, please. So back to where we were in 2004, the FDA permits production and marketing of medical maggots, again, for debriding of non-healing necrotic skin and soft tissue wounds, including pressure ulcers, venous stasis, neuropathic foot, and non-healing traumatic or post-surgical wounds. Next slide, please. There are some warnings in using maggots. There might be allergy. You have to just be sensitive to that possibility. I've never seen it myself, but it is possible. Pain or discomfort. I have found that in the hundreds of maggot treatments that I've used, very unlikely, very uncommon. I've had 1 or 2 cases where there was pain, but usually not. And you want to ensure sterility, prevent contamination. It's single use only. You put the maggots on, take them off, and you're done. You want to prevent escapes. You don't want the maggots to get out and have flies running around anywhere. So you have to inspect your patient and the dressings frequently. Do not close the wound over the maggots. And if the patient has a fever or altered mental status, you want to thoroughly evaluate. And you handle your maggot dressings as infectious waste. Use biohazard bags to get rid of them. And you need to be aware of Pseudomonas wound infection, probably, possibly. Okay, next slide. Adverse events that are most common would be pain or discomfort. Published studies say 5 to 30%, but I've had much less than that. Out of my hundreds of patients, I've had maybe 2 that had pain. And the pain only happened when the maggots were working on the toes, like between toes, and there wasn't much space there. And as the maggots get big, they pressed on nerves there. Anxiety, they had in studies only 5% decline maggot. I have never had anyone decline. I have 0% declining. You know, people are very happy to have maggots, in my opinion, in my experience. You know, it's how you present it. You know, you say, you know, you got this wound here and it's got some trouble and we need to fix this. And here's some things that we could do. We could cut it out. We could, have you ever seen 2020 or anything of maggots? Yeah, my sergeant in the Army had that, you know, or yeah, I watched it on the show. And I said, well, those can be our little friends and we could have our friends come help us. and I've never had anyone decline. Then maggots, you have to time it very carefully. They need to, from the time that they hatch out and are larvae, you have about 24 to 48 hours that you have to put them on a wound. Otherwise, they're going to die. So delivery has to happen, and you have to have everything timed so that you can get them in time and put them on and run it that way. But I don't think that happens real often. They've had here 1 to 2%, so that's not too bad. Next slide, please. So let's look at some case studies. Okay. Whenever I use maggots, it's for debridement, biological debridement. It's very cost effective. It's painless, usually. It's highly selective. I can trust the maggots. I know that they won't harm any healthy tissue. They will only take out the bad stuff. It treats infection, and you can avoid amputation. Okay, next slide. Pro, it has always been well received by patients and families. It's easy to do. It's low tech. It's very social. It's safe. It's economical. It's social. I mean, I remember just rooms full of people wanting to see the maggot therapy, and patients being queen of the day, whatever, because everyone was coming to see them get maggot therapy. A con would be it is time sensitive, and there are staff and facility perceptions which are sometimes negative. And availability, can you even get the maggots? So if you know how to get them and you can get them, then that's not an issue. Next slide, please. Okay, so we're going to look at some cases here. This is case 1. She's an 84-year-old woman who had a stroke and diabetes. She's tube fed. She's on a low air loss mattress. She's very lethargic. She has a fever. She's on IV antibiotics. She's sick because this wound is infected. The room smells terrible. You can smell it when you walk in the nursing home. The family refuses any surgery or OR. They said, no way. And currently they're treating wet to dry daily, clean with C-cleanse. Next slide, please. So is that treatment helping? Not at all. And it's not a stable heel ulcer. It's infected. It has to be debrided, so what needs to be done? And what are appropriate goals for this patient? Now this was a hospice patient, and some people would say, she's hospice, just let her die, just treat her with IV antibiotics, and what happens will happen. But I was there and I said, well, I think we could get rid of the odor. We could treat the infection. We could maybe improve her quality of life. And the nursing home, no way were they going to do maggots. But the daughter was thrilled with the idea. She said, my mom would love this. And she convinced the nursing home that we were going to do maggots. So we did maggots. But I'm thinking of Diana, you having to argue for 10 days. So she argued for 1 day, and we got maggots. And so we did maggots. That was our goal. Next slide, please. And we did 2 rounds of maggot therapy. A round is 48 hours. I did 1 a week for 2 weeks. And this is what her wound looked like. You saw that black heel ulcer. And this, after 2 rounds of maggot therapy, this is what her wound looked like. She had no pain. She was more alert. She had reduced odor, and she had no more fever. She already was much, much better. Her quality of life was much better already. And you can see the white is zinc oxide ointment, part of the dressing that we put on the wound. Next slide, please. And 4 months after, this is what her wound looked like. It only needed a Band-Aid to cover it. And she lived months longer, you know? Now, here was a lady that was going to die, and we saved her with maggots. And was that the right thing to do? I don't know. She was much better. Her family was very happy, and the facility was very happy with the total outcome. And they got over having to do maggots. Okay, next slide, please. This was one of the, again, I'm using my favorite cases. This one was very special. This was a 64-year-old man with diabetes, and how he had this foot wound. He had end-stage renal failure. He had peripheral neuropathy. Thank goodness he had no pain. He couldn't feel anything. That wound was infected with MRSA, methicillin-resistant Staph aureus. He had liver failure because of the antibiotics they were using to treat the wound. And nursing home, this man was walking around in the nursing home, and he had this draining, infected wound. And they were putting charcoal dressing and ABD with saran wrap 3 times a day on the wound. And the patient refused amputation. Okay, next slide, please. So the main problems are odor and infection. He apologized to anyone that came into his room. I'm so sorry that I smell so bad. And treatment's appropriate? No, of course not. They had never even washed that wound. I went into a room and really hosed the wound, hosed the foot down when used dilute bleach, got rid of about 75% of the problem. And, you know, I looked at what are treatment options. Well, we want to get rid of the infection, and we can't cut his leg off. And I really did not want to cut on that foot the way as much as I would have to. So I offered him maggot therapy, and he was thrilled. He said, that is a great idea. And my wife wants to help too, and we want to help put them on and take them off. I said, great. So he was all gung-ho about it. Next slide, please. I told him I didn't know what to expect. This was after the first round of maggots. You can see it looks a lot different already. You can see that when you see the bone sticking out up there on the top right, that was where that infection was. And we did, I think, another round or 2. Next slide, please. And it just continued to shrivel up. Now you can see the bone exposed there. And next slide, please. And that's his end product. A very innocent foot, not very pretty, but no odor, no infection. If he lived long enough, that other foot was going to be a problem. But he's walking around very happy, and his family was very happy, and the nursing home was thrilled, you know, because they got rid of their walking around infection and had a very happy, satisfied patient. Next slide, please. This one is a very unusual case. This was a 58-year-old woman with rheumatoid arthritis. She had sudden onset of foot pain and swelling. She had vasculitis with arterial thrombosis. She came from a hospital. They'd offered her amputation of the leg, and she said, no way. So she came from the hospital, came to our office. This is what her foot looked like. Okay, next slide, please. And we used maggots on her, which I don't have pictures of us putting the maggots on, but we used maggot therapy. And a week after she came, this is what she looked like. Pretty, her foot is very deformed from her rheumatoid arthritis. So keep that in mind. Her toes are crossed over and things like that. Next slide, please. And 6 weeks later, here she is. It's looking much better. You're seeing 2 toes are gone, and you have black on the 2 toes remaining, but we're looking a lot better. Next slide, please. This is 4 months. Again, you can really see the healing that's happening. Next slide, please. 8 months, really looking good. Now, the toes are always going to be bent and deformed like that because that's part of her baseline condition. Let's look at the next slide, please. And here she is on the left is what her foot looks like 10 months later. And she got special new shoes, and there she is with her new shoes on. Now, I have to say, this patient, in the 10 months that we treated her, she never missed work. She went to work with maggot dressings on her foot. She always worked the whole time. She never missed work. And now she is with shoes, and she's still working. So I thought that was a very impressive thing that she did. Right, next slide, please. It's our last maggot case. This was one of my first maggot cases. This is a 93-year-old woman with end-stage dementia. She's bedbound. She'd had a right above the knee amputation, so she only has the left leg. And she's tube-fed, and she's had this non-healing wound for over a year. Nursing home has tried everything, and nothing works. Okay, so I said, well, you've tried everything except maggots, so we ought to try maggots. And they said, okay. Next slide, please. So we got some maggots. Next slide, please. And we put them on, and 40 hours later, this is what it looked like. The maggots were cleaning up and debriding away. And next slide, please. And you rinsed them off, and what a beautiful debridement. I looked at that and I said, there's no way I could have ever done as good a job with a scalpel. And they were really, really good. Now, the funny thing is she was on the way to the ER because they said her toe is blue, her big toe is blue. And I thought, what's that about? It's not the maggots. And turns out in the ER, she had pathological fracture of her tibia and her fibula. So they put her in a splint and sent her back to the nursing home. And her doctor said, oh, she has to get a cast. She has to go to the orthopedist. So she went to the orthopedist, and he put her in a cast from toe up to knee. And I called him up and I said, you covered up our wound. And he said, well, that wound's going to heal fine. I said, but can you cut us a hole in the cast so we can look at the wound? He said, okay. Okay, so he cut us a hole in the cast. So every week, the nursing home dressed the wound, looked at it and dressed the wound. Next slide, please. 6 weeks later, she gets her cast off, and here's her wound, healed up. I'm like, wow, so much for what I wrote. This wound will never heal. Wrong, it healed beautifully. And her cast is gone, and her wound is healed, and they don't have to treat it anymore. That wound was from a bunion surgery. Why she had bunion surgery, I don't know, because she never walked, didn't wear shoes. So next slide, please. So for maggots, always assess the whole patient, use evidence-based practice. You debride, you clean, you treat infection and pain, and you select a dressing. But your treatment always needs to be consistent with your goals. Okay, next slide, please. Any questions about maggots? You'd be like this student. May I be excused? My brain is full. Next slide, please. So now let's talk about leeches. They're not as scary as you might think. Next slide, please. Hirudo medicinalis is the leech that we're talking about, the leech that we use. I get my leeches from Leeches USA, which they come from France. I've never tried to speak French to them. Next slide, please. Leeches come from throughout Europe. They're a near protected species because of overfarming and habitat reduction. Leeches USA come from France. And with Leeches USA, you can get overnight special delivery. And that comes to what they're mainly used for in the US is to salvage flaps, surgical flaps. And they need them sometimes urgently, but you can call over and get overnight special delivery from Leeches. Next slide, please. And what are Leeches used for? Well, historically, bloodletting for all kinds of reasons. Worldwide, the routine treatment for many conditions. I know in Russia, they use them a lot for hypertension, all kinds of oral conditions. And I know in Turkey, that's almost like you got to get leech treatment once a year or you're not okay. And in the US, though, they're most commonly used for failed surgical flaps. Off-label uses could be for venous stasis, peripheral neuropathy, arterial insufficiency, and edema. Next slide, please. How do they work? The anterior sucker has teeth that bite and the leech sucks blood. There are about 60 different proteins produced in the saliva that are injected in the bite wound. One of the things injected is hirudin, which is an anticoagulant. One of the best anticoagulants there is. There's platelet aggregation inhibitors, such as collagenase. There are vasodilators and proteinase inhibitors and anesthetic. So leech bites are not painful. A leech will suck until full. Maybe it takes 2 hours. Usually 5 to 15 milliliters of blood is taken. Post-bite bleeding is the most important part of the procedure. So you want the blood to keep going after the leech has bit. A leech can live, it says here, a leech can live for a year after a bite. But in the US, FDA requires destruction after single use. Actually, leeches can live a lot longer than a year. They can live up to 20 years, but you can only use them once and then you have to get rid of them. Next slide, please. Some kind of fun things to know. In 1831, Manchester Royal Infirmary used 50,000 leeches at a price of 1 penny, 3 pence, half penny each. Leeches today are $12 each. In 1832, leeches were more than 4% of total hospital expenditure. And the hospital maintained an aquarium for leeches until the 30s. The hirudin, the anticoagulant, is synthesized using recombinant techniques, not practical to harvest from leeches. Hirudo medicinalis is the European medical leech. The Asian medical leech is Hirudo menalensis. The North American medical leech is Macrodella decora. Other species used medically include H. orientalis, H. trochtina, and H. verbena. But medicinalis is the one that we know and love. Next slide, please. Here's some examples. Next slide. I had a patient that had severe peripheral neuropathy, and he had hemochromatosis, so he needed to go for phlebotomy routinely. And one day he was in the office and I said, you know, what if we use leeches to draw your blood? And he said, okay, why not? So we brought him into the treatment room and put 8 leeches on his legs and 4 on each leg. And it was amazing. Right in front of our eyes, his skin turned pink instead of pale, and he got his sensation back. He could feel, and it was amazing. And, you know, I don't know how many other people use leeches for peripheral neuropathy, but it certainly worked for this man. He liked it so well that he came back every month for treatment. And of course, it took the blood out, which he needed for his hemochromatosis, but it improved his neuropathy. He had feeling back, and that was wonderful. Next slide, please. And here was a man with venous stasis. And I don't have pictures of us treating him, but we did treat him. And I had a hospice patient whose legs looked very much like that. We treated him with leeches. We used 8 leeches, 4 on each leg. And within 2 hours, the leeches were done and the redness was gone, the swelling was gone, the drainage was gone. His legs looked wonderful. And with all the nurses who were helping, we're all like, wow, how did that happen? You know, just right in front of our eyes almost. So it really can help with venous stasis. And I don't have any other stories of leeches to tell you. Next slide, please. But in summary, leeches are safe and simple to use. But getting them to bite on, it can be difficult, let me tell you. They are gentle and painless. You do need to give antibiotics prophylactically. I usually gave them a dose of Cipro. Blood loss can be significant. I know in Russia, they do most of their leech therapy in the hospital, and they transfuse if they take out too much blood with the leeches. So it's not scary at all. Next slide, please. So that's how you can contact me if you have any questions. And that's it on maggots and leeches. Okay, any questions? Albert, have any questions?
I have some questions, if not, or while Albert is looking through for questions. Can you hear me okay?
I
There
can
we
hear.
are. We're back on screen. That was a great talk, Dr. Tippett, and indeed, I learned many more things.
Really?
And I have many, many more questions.
Okay, let's have them.
First, a brief comment. We can always use more controlled prospective leech studies. And the Better Foundation is trying to organize some controlled scientific studies of Hirudo therapy. So if there are any therapists, leech therapists out there watching or listening to this, who would be interested in participating, contact us. And we'll tell you more about what we have and maybe how we can support you or how you can support leech therapy in this way. So one of my questions, and I wrote them down as we went along. What has been your experience, if you can give us any more details about working with doctors or nurses or other support staff in terms of wanting to treat your patients with maggot therapy, how they reacted and how you dealt with how they reacted?
Well, certainly at my hospital, I used maggots at the hospital, and they wanted to develop a maggot protocol. So the hospital developed a maggot protocol that made it officially okay to use maggots, you know, in the hospital. And most people said, whatever, you know, but they were very receptive to the whole idea. And I think, you know, I'm recalling times where we did maggots in nursing homes and the word went out that we were doing maggots and the room was filled with people. It could be medical students, you know, nursing students, all kinds come in to see what's happening. You know, so in general, they weren't real opposed or negative. They were kind of interested and eager to learn, but don't let me do it. Don't make me do it. I just want to see it.
You mentioned a number of cons, pros and cons associated with maggot therapy. Did you have any other obstacles outside of those common cons or difficulties?
Not really. I never have. I mean, I've only had my own experience, and it's 20 years and hundreds of cases, but I've never had anything other than those. No.
Albert, any questions you've seen come through?
No, Dr. Sherman, I did not find any questions on the Facebook stream or the Zoom chat.
Well, then I guess I have some more time to talk with Dr. Tippett.
All right.
I want to really thank you for addressing the issue of maggot therapy as palliative care.
Thank you.
In
It's
my
great for palliative. It's wonderful for palliative.
I found that to be so also. And I was surprised when I received resistance to the idea of maggot therapy as palliative care. Frequently, the excuses of, well, the wound is not going to heal, or our goal is not to heal the wound anyway. And sometimes these comments came from the same people who argued against using maggot therapy outside of palliative care because the maggots aren't going to heal the wound. And now they tell me, well, we're not trying to heal the wound, so we don't really want to use maggot therapy.
Right.
It
right.
makes sense.
Oh, maggots are wonderful for palliative care. I mean, we had one, even though this hospice says they won't allow maggots, they, I guess, didn't realize I was using maggots a couple years ago on one of the patients to get rid of the odor. And it totally got rid of the odor. You know, people said, well, now what? I said, nothing. You know, this patient's dying, but there is no odor. We got rid of the odor.
And getting rid of the odor is so important and so much a part of palliative care.
It is. It's the pain and odor. Those are the two big things. You know,
I would
get rid of odor. That's what with the foot. We got rid of the odor. You know, his foot wasn't very pretty, but we got rid of the odor and we got rid of the infection.
I think too many people don't realize that odor is not simply a problem for the therapists that have to walk into the room. It's a problem for the patient, even though they may not express it. And it's a big problem for the patient if they are embarrassed to invite family and friends into the room, or if the friends and family are uncomfortable from the odor and don't want to go and visit the patient. It is a big impediment on many levels.
It is. Odor is terrible. It's a very down thing to have, and maggots can help. So
you also,
I would like to see more people open to using maggots. Go ahead. What?
You also mentioned how they control the infection and pain, because a lot of the pain is due to the infection.
That's correct. And, you know, like my one poor lady that we used the maggots on her heel, her pain, I mean, she wasn't a very verbal patient. She was laying there pretty much out of it in bed, but she wasn't in pain anymore. And the odor was much improved. And, you know, she was very much more alert and happy with what was happening.
So for anyone who finds themselves dealing with a patient in hospice or contemplating hospice, or even just talking to someone about hospice care, having dealt with that not only professionally, but in terms of my own father, who was in hospice care, and listening to the medical people talk to him, I have to emphasize from both a practical standpoint and from the standpoint of how it feels as a patient to hear them, the communication about what hospice is about is not about not providing care, not sending you to the hospital. It's not about, you know, not doing anything invasive. Those are simply modalities or methods to achieve the true goal, if I can be so bold as to say the true goal is comfort.
That's correct.
And too many people forget that and just say, well, we're not going to do this. We don't want to do this. That's not what hospice is about. Forget that hospice is about making you comfortable. And if making you comfortable means removing some fluid off your chest so you can breathe, if you're okay with it, or removing the, or doing maggot therapy to simplify the dressings that have to be done all the time and this and that, when maggots can make it a clean wound and you don't need some of those other irritable treatments. That's where the aim should be.
That's a really good point. You know, there's something that I meant to talk about during my talk and I forgot was, you know, maggots are FDA approved for debridement. And I know people have talked about, can you get paid for using maggots? I've always billed for debridement, just the debridement code, whether it was like superficial. I always looked at how deep I was debriding, depth, and billed the code for that. Never got turned down, never got turned down. Now, I never mentioned maggots, so I figured they don't care how you do it. They just say debride. They don't care if you're using scissors or scalpel or maggots or whatever, you know? So that's my 2 cents on billing for debriding with maggots.
That's very helpful because it's a common concern I hear all the time.
Yeah. So I don't, you know, you don't have to, you just, it's a useless thing to say, pay me for maggots. They're not going to pay for maggots, but they will pay to debride, you know, and that's fine. They pay very well for that. So it almost covers the cost of the maggots. Not always, but usually does.
And for those patients who don't have insurance or something, for those patients that don't have insurance or financial resources, the Better Foundation does have a fund to subsidize the cost of maggots.
Oh, really? That's very helpful. Very helpful for some people.
Albert, any questions come through?
No, no questions.
Albert, you're hogging all the questions.
Your presentation was very thorough.
Didn't leave any room for questions.
There may be questions from those who watch this video afterwards, and they are free to contact us. And we can put them in contact with you, Dr. Tippett, if it's appropriate.
Oh, that's fine. That's fine. No problem. And I put my contact information on the side, so if anyone can contact me if they want to.
Very good. Well, I'm going to take just 2 more minutes then to both elaborate on your recommendation, Dr. Tippett, and exonerate myself if I can at all. You touched upon another important element regarding consent, and that was how you present the information. I have heard clinicians talk to their patients about maggot therapy and begin with an opening line such as, "You're probably going to get very grossed out, but," or they say, "You won't believe this. I couldn't believe it when I first heard about it either, but they're actually doing this." And then proceed to discuss the therapy with a patient. And of course, that is not the way anyone would introduce a treatment that they believed should be administered.
Well, I think people are much more receptive to hearing, let's ask our friends to come in and help us, you know, because the maggots are our friends. And people like that.
So the published study, which shows only a 95% consent rate compared to your experience of 100%, that was my study. So I need to defend it now.
Okay.
And why did I only get a 95% consent rate? Well, in my defense, all of the patients that I discussed maggot therapy with in 1990 through 1994, this was 1990 through 1994 or 1995, the patients consented, but not all of those patients were able, competent, conscious to give consent on their own. So as it happens, those non-consents were all patients who couldn't consent for themselves, but I had to get consent from their conservatives. So that makes it sound a little bit better. And it's important for people to know, just as you said, patients are not that reticent to undergo a trial of maggot therapy when they are living with a chronic, non-healing, draining, stinking, limb-threatening, often, wound.
Yep.
A bunch of baby flies is not really that bad in their context.
Yeah. I have patients that turn their flies loose. They didn't want to destroy them. You know, they go home and they tell me, I let them go because they saved my life. Why could I let them go? You know?
I have experienced the similar sympathies. Had one patient who wanted to name them.
Oh, yeah. One guy with the foot, he named all his. Oh, that's Harry and that's Joe.
And so you commonly read in the literature about clinicians who say their patients would never agree. They don't do maggot therapy because their patients would never agree to it. And
That's
it's
not true.
really not my experience. And I'm glad to hear that it's not your experience either.
No, I would totally disagree with them. I say, you just don't know how to ask.
Or
You
are
don't know how to
using
present it. Yeah.
Right. Not presenting it or don't want to ask. That's an
Yeah.
excuse.
Yeah.
And it's propagated though in the literature. Well, it may be of interest to you to know that of those conservators of my patients at the VA Medical Center in Long Beach, when the wife of the patient was the conservator, all agreed to let me place maggots on their husbands. When the conservator was a lawyer,
They wouldn't.
or in one case, a brother, they were not too keen on allowing me. And at that time, in the 1990s, the consent was a research consent. This was all research. It was not FDA cleared. It was not being done as general practice. It was done as an undergraduate's, a postdoc's research project. And so it had a different aura about it as well. In any event,
I would think at the VA, your patients would love to do maggots. You know, that's where maggots came from, is the military.
not only did they love it, but they loved the facility's restrictions. The hospital did not want anyone to find out that maggot therapy was being done.
Oh, really?
So they required all study subjects to be treated in a private room without any other patients around. So imagine how easy it was to consent patients, telling them, I'm sorry, but you're going to have to move into a private room.
Yeah.
Because the VA was all 4 beds per room otherwise.
Yeah. Well, that helped you.
With that, I'll ask one last time of Albert to check and see if there's any final questions.
I do not see any questions.
Well, I had a delightful time, Dr. Tippett.
Thank you. I had fun too. Diana, how'd you do?
I enjoyed it. The one thing I wanted to comment on is that, when your presentation, it was very good. You show mainly people that are diabetic or, really, really severe wounds on their feet. But for my case, I had a post-surgery wound.
Yeah.
I'm diabetic. I have no.
Of course, I'm mainly working with hospice. So
Yeah. So I think
usually the end of the road people,
Yeah, so my point is, and I think that's why my wound care doctor was he had never heard of it. Like, oh yeah, he never heard of wound care therapy. But if the word could get out to surgery centers, I can't believe the person who walked out with a post-surgery necrotic wound, and he was debriding it and killing it and making it worse. It was just unbelievable what I went through until I finally said no more. And then his solution was flap surgery, take a muscle out of my back, all this crazy.
Yep. That's what they want to do. Either cut it off or do a flap.
And I said, no, I'm a medical professional myself. And I had heard about this in my medical training about maggot therapy, but I didn't know anything about where to start, where to get it, what do I need? And luckily I met Dr. Sherman. I reached out, I'll go find my answer. And then
I'm glad you did it. I'm glad you did it.
I am so thankful. And the one thing I want to say about the pain, I didn't experience pain with them because of their healing secretions out of their mouth, that they call in mast cells and all the antimicrobial agents. Every time I put those maggots into that wound, I did like 5 applications. It was trial and error for me because I had to take over applying them myself. My wound felt soothed. It felt so happy. It was
happy because it was what it needed.
Yeah, and I never had to go on antibiotic therapy either. So I did everything. So it was a beautiful.
That's great. That's awesome. That's a great story.
I'm thankful for that treatment. I would recommend it to anybody.
Well, great. Thank you very much.
Diana, you make a very important point, not only about your experience, but about needing to get the word out.
Yes.
And that's why we are all so grateful for your efforts in that direction by sharing your video on YouTube of your experience. And we certainly, the Better Foundation, we certainly welcome any efforts to share the word the more people who know their options, including biotherapeutic options, the better they can select the right option. A lot of people don't even think about maggot therapy until the wound is almost ready for amputation. On the Better Foundation's YouTube homepage, there is an animated film that describes that, how therapists say, it's not bad enough, it's not bad enough. We have lots of other choices. And then after nothing works, they say, it's time for amputation. Well, what about maggot therapy? Oh, it's too bad now. Maggot therapy won't work anymore. What happened to maggot therapy from not bad enough to too bad it won't work?
Yeah.
That's the normal timeline. But as Dr. Tippett pointed out, experience with maggot therapy, for those who have had experience, usually initially on some horrendous wound, whether or not they can save it from amputation, only about 50 to 70% of wounds scheduled for amputation can be healed and avoid amputation in published studies, but that's still 50 to 70%. So whether or not they have saved that wound, they see what the maggots can do and then start to incorporate it, not as their last choice, but as their fourth choice or their third choice and so forth. It goes up the hierarchy because it's relatively safe, simple, inexpensive. It moves up the ladder of choices for wound care, but it usually starts as a last resort. So keep spreading the word. We will do our best to share with programs like this and our newsletter and our financial support where we can give it. And hopefully more and more people will recognize it as an available option. So again, thank you all for joining us. And with that, I'll say goodbye, good night. Thank you.
Bye-bye.
Thank you.